Okay, so welcome back everybody. Welcome back to the Emergency Psychiatry Lecture Series. I'm Dr. Swaleha Mujawar, Assistant Professor. And today we are going to learn about depressive stupor and catatonia. These are two very important things that you see in the emergency department, and you'll probably not be able to understand what the patient is if you don't know what this is. So knowing how to identify these two cases and a little bit on the management. So what is depressive stupor? First we'll learn about that, then we'll learn about catatonia. So depressive stupor, it is quite rare. Both catatonia and depressive stupor are rare. And what is this? So do you know what stupor is? What is stupor? कोई idea है? Confused state or confused से ज़्यादा it is a unreactive state and a patient is not reacting to the external stimulus but इतना नहीं है कि वो कोमा में जा रहा है तो it is something in between delirium and coma. So stupor though is the same as the stupor that you know, and when it occurs in the form of depression या along with depression, तो उसको depressive stupor बोलते हैं. Basically, when a patient is depressed, तो patient says कि हाँ कुछ काम करने का मन नहीं करता है, बेड से उठने का मन नहीं करता है, तो this is psychomotor retardation जो हम लोग बोलते हैं. So sometimes when the depression is very severe and there is a profound psychomotor retardation, there might be mutism, there might be nearly complete lack of responsiveness, then this is called as depressive stupor. कि डिप्रेशन में उसको हिलने का भी मन नहीं कर रहा है and the patient is not responding at all to the external stimulus. It is rare, it is life threatening, and it often requires intensive medical and psychiatric intervention. So that is why we are learning this today. So just a little bit about depression. What is major depressive disorder or depression? It is a common mood disorder that affects millions worldwide. While it is typically characterized by symptoms like sadness, fatigue, loss of interest, it can also manifest in a more severe form, that is depressive stupor. So basically this is a extremely severe form of major depressive disorder. So what are the key characteristics of depressive stupor? One is lack of movement and prolonged stillness. So like I said, patient says कि bed से उठने का मन नहीं करता है या कुछ करने का मन नहीं करता है. तो patient is not moving at all. कुछ करने का मन नहीं is like the severe वाले फॉर्म में अगर जाए तो हिलने का भी मन नहीं करता है. तो देर इज एक्सट्रीम immobility, there is a state of prolonged stillness, and this is there for extended periods of time. Mutism, what is mutism? A complete absence of speech. It is a defining characteristic of depressive stupor. Individuals may appear unresponsive to verbal cues. जो आप ग्लास्को स्केल लगाते हैं तो verbal cues में भी patient does not respond, unable to communicate verbally. ओके सो दिस इज अगेन द सिवियर फॉर्म. जैसे डिप्रेशन में पेशेंट सेज कि किसी से बात करने का मन नहीं करता है या देर इज डिक्रीज सोशल इंटरेक्शन, देर इज डिक्रीज्ड स्पीच इन डिप्रेशन. बट टेक इट टू द वेरी सिवियर फॉर्म और द मोस्ट एक्सट्रीम फॉर्म, it is mutism. There is also emotional withdrawal and numbness. So individuals in a state of depressive stupor experience profound emotional detachment, often feeling emotionally numb and withdrawal from their surroundings. So again, this is again a part of depression. So patient feels emotionally nothing or maybe very severe sadness. There is severe psychomotor retardation. So this refers to a significant slowing of movement and responses, making it difficult for individuals to perform even the simple of the tasks. So what are the key characteristics? Lack of movement, mutism, emotional withdrawal, and severe psychomotor retardation. So if a patient comes to you with these characteristics, always think about depressive stupor also. So what are the underlying causes? Why does this occur? So like all psychiatric illnesses, it has a biopsychosocial etiology. So we'll look at the biological, psychological and social factors. So what are the biological things? There are imbalances in neurotransmitters. So the most common neurotransmitter associated with depression is serotonin, but dopamine and norepinephrine are also disturbed. These are the chemicals that regulate mood, motivation, energy, and a deficiency can lead to extreme lethargy and withdrawal, which is seen in this condition. So you have three neurotransmitters, serotonin, dopamine, norepinephrine in your brain, which are very, very less. And this leads to depressive stupor. Psychological factors like trauma, some abuse, psychological or physical, or loss of some loved one. This can also trigger depressive stupor. Prolonged stress can also disrupt the brain stress response. The hypothalamic pituitary response, which is the stress response, that also gets disrupted after prolonged stress. So it also contributes to the development of this condition. Social factors like social isolation, lack of social support can worsen depressive symptoms and increase the risk of depressive stupor. So you'll see that these patients lack strong social network and they struggle to cope with stress. They're not able to seek help, and this further isolates them. So these are again the things probably in history which you will find that there is some trauma, there is some social isolation, and there is some stress. So again, if the stupor is occurring after a period of stress or trauma, again you should think about depressive stupor. Now coming to the diagnosis and treatment. So in differential diagnosis, a thorough evaluation is crucial. So we have to rule out other causes because like I said, stupor is a very vague symptom or a very big symptom in which there can be other differential diagnosis. The most important is a neurological disorder. So you need to do a thorough CNS examination, rule out any neurological condition, ask about substance use in history because some substance withdrawals also can cause stupor, and of course any other medical condition. So this process involves gathering a comprehensive medical history, a physical examination, any relevant lab test you feel like, do you need to send serum electrolytes, do you need to get a CT, MRI done, and the goal is to identify any underlying medical issues that might be contributing to the patient's symptoms, because a lot of times we feel और you'll see emergency में कि पर्चा है patient के पास कि depression का patient है और just ये कर दें कि बस इसको और कुछ तो हो ही नहीं सकता. So this is what we want कि हाँ patient might present with depressive stupor, but we need to rule out other causes also. So in medical evaluation, assessing physical health is critical as some medical conditions can also present with symptoms similar to depressive symptoms. So we have blood tests like electrolytes. So serum electrolytes, so definitely, if even if the patient is a psychiatric patient, sending serum electrolytes, I feel not even in depressive stupor. All cases, I think a serum electrolyte is very important because it is a life and death situation. If the electrolytes are disturbed and if you don't treat it immediately, then the life is at risk. Thyroid functions are also important, and of course medically you all know better actually, so what tests to send and how to rule out all other medical illnesses. Now coming to catatonia. So this is also a very, very rare syndrome. In fact, it used to be very common in the historical or probably 30, 40 years back, but now it is very rare, and we have a case of catatonia actually in the ward. So if you want to see, Dr. Ria or Dr. Shamashish will actually take, and it is very rare. So it is good you can actually go and see the patient, and maybe you will understand this catatonia much better after seeing the patient. So what is catatonia? It is a neuropsychiatric syndrome characterized by abnormal movements, behavior and unresponsiveness. So it can occur in various psychiatric conditions but also in medical conditions, including schizophrenia, mood disorders, medical illness. So that is why we have taken this class for you, because again there is a very big overlap between medical causes and psychiatric causes leading to catatonia. And catatonia again is a symptom, just like stupor. It can have a very long range of differential diagnosis. So first we'll see how to identify catatonia, and then of course the treatment. So by definition, catatonia is a unique syndrome characterized by unusual movement problems. So movement is the key word here. There is abnormalities in movement. So patient might freeze in places, resist movement or mimic others' actions. This can lead to a wide range of clinical presentations. So, catatonia isn't tied to just one mental illness, like schizophrenia. It can actually occur in bipolar also, it can occur in depression also, and the presence of catatonic symptoms significantly impacts the treatment also. And what is the distinguishing factor? It is crucial to differentiate catatonia from other symptoms. So a careful evaluation of history and specific behavior is essential, and differentiating catatonia is very, very important. So the key symptoms of catatonia that you have to keep in mind. One is immobility. So immobility again, catalepsy or stupor. So patient can have posturing for a very, very long time. So patient will assume one single posture for a very long time, and this assuming posture for a long time can be again so severe that the patient is unresponsive. Mutism is again there in catatonia also. Posturing is there. Posturing means holding a specific position for for an extended period, even uncomfortable. So for our patients, we usually take their hand and we put it over their head. So in normal patients, this is a very uncomfortable position. And even if you put it there, normal patients will take it down. But in these patients, catatonic patient, they might hold it for hours also. They might not take it down. Another very important thing seen in catatonia is waxy flexibility. So what is waxy flexibility? That their limbs are like wax. You can move them very easily without any resistance from the patient. So again, when you're taking it to uncomfortable position, most patients might resist it. Like if you take it on the other side or something, they might either feel pain or uncomfortable. But these patients, their limbs are so flexible that you feel like you're actually moving a wax figure or a wax limb. So these are some symptoms. So we have immobility, we have mutism. These were there in stupor also. But posturing and waxy flexibility are seen specifically in catatonia. Now coming to some other additional features. One is negativism. So negativism is very different from mutism. Negativism means resistance to instructions or attempts to move them. So on one hand, some patients might be super cooperative that you are able to move their limbs like wax, but some patients will resist each and everything. So whatever instructions you are giving them, they are doing actually the opposite or they are not doing it. So this is negativism. Echolalia, ecopraxia. Echolalia is the repetition of words. Ecopraxia is the repetition of actions. So whatever you are saying or whatever you are doing, patient will mimic this. So echolalia, ecopraxia again seen in catatonia very, very commonly. And according to these symptoms, then we have the types of catatonia. So we have stupor and mutism. So in this, there is extreme immobility, lack of responsiveness. Individuals remain completely still and they are unable to communicate due to mutism. Sometimes patient can be agitated also. So it is not necessary that the catatonic patient will be lying or not moving at all. Patient might be actually aggressive. There can be excessive motor activity ranging from restlessness to agitation to disorientation. So these patients might pace, they might exhibit repetitive behavior, so they might do one action again and again and struggle to control their movements. Negativism, we've seen, is a resistance to instructions and suggestions. Individuals may refuse to cooperate with requests or actively resist any attempts at movement or interaction. And then we have again echolalia, echopraxia, this you know. So these are the types of catatonic symptoms. So it can range from anything from zero movement to a lot of movement. So it's actually a spectrum. Patient can do anything in between and all these will constitute catatonia. So what are the different disorders in which catatonia can occur? We as psychiatrists, we see it most commonly in schizophrenia. In fact, a type of schizophrenia is called as catatonic schizophrenia. Sometimes it can occur in mood disorders also like bipolar disorder, major depressive disorder, but it can also occur in neurological and medical conditions. So neurological and medical conditions like autoimmune diseases, substance withdrawal. So always keep in mind that this can also be a cause of catatonia. So in causes, we have neurobiological causes. So catatonic symptoms can arise from disruptions in brain chemicals like again dopamine. So dopamine was common in stupor and catatonia, but here we have GABA and glutamate. In fact, GABA and glutamate are the new research molecules. Every research is now focusing on GABA and glutamate. So these are abnormal. These neurotransmitters regulate the brain activity and communication. And imbalances can lead to unusual movement patterns and changes in thinking. So this is the neurobiological cause. There can be psychological causes again like trauma, stress, psychosis. These experiences can significantly impact the brain function and increase the risk of developing catatonia. Medical factors. So a lot of medical factors, a range of medical factors can trigger catatonic symptoms like infections, metabolic disorders, and again substance abuse. So that is why a thorough medical evaluation is very, very important to rule out all other causes of catatonia. Coming to treatment, so what are the types of treatments available? One is pharmacological interventions. So we give medications like antipsychotics and benzodiazepines. They can help manage the symptoms. Antipsychotics are usually given when there is agitation and some psychotic symptoms like delusions or hallucinations, while benzodiazepines, they usually decrease the anxiety and muscle stiffness. So depending upon the patient's symptom, we give the treatment. So the patient that we have in our ward, we are giving both antipsychotics like olanzapine and we are giving benzodiazepines like lorazepam. So these are the two treatments that she is receiving. A very effective treatment is ECT, the electroconvulsive therapy or shock treatment, which is colloquially known. But again, ECT has a lot of uh, problems in the form of one, we have to get a anesthesia clearance done, and second, it is not very well received by the patients and the relatives because they feel that, oh, you're giving shock treatment, even though it is very, very effective for severe catatonia, especially when other things have not worked, but still it is becoming very rare and usually it is not given. It involves a brief seizure, using electrical currents, and this can improve brain functions. It reduces catatonic. It is very, very effective, but unfortunately very rarely done. Sometimes psychotherapy also works. So supportive therapy, cognitive behavior therapy can help individuals cope with catatonia. CBT is becoming like the most common therapy, or the most well received therapy again. So it focuses on identifying and changing negative thoughts and behaviors, while supportive therapy offers emotional support and guidance. Last but not the least is the multidisciplinary approach where you guys come in. So treating catatonia often requires a team of professionals like psychiatrists and neurologists. This collaborative approach ensures that the individual receives the most appropriate care for their needs. So, not just a psychiatrist, a whole team, if they are treating, then it is better. So now that we know what is depressive stupor, what is catatonia, let us understand and differentiate between the two. So depressive stupor is a severe form of depression characterized by extreme withdrawal, inactivity and lack of responsiveness. Individuals may appear unresponsive to their surroundings and struggle to engage in basic activities. Even eating and bathing, getting ready, all these things also will be absent. Catatonia, on the other hand, is a state of immobility or excessive motor activity, often accompanied by odd movements, negativism, echolalia. So while both conditions involve significant disruptions in motor behavior, they differ in their underlying causes, which we have seen, and associative symptoms. For instance, catatonia can be triggered by various medical conditions, while depressive stupor is primarily linked to depression. Additionally, while catatonia may involve periods of excitement or agitation, in depressive stupor there is always extreme lethargy and passivity. So depressive stupor will never present with excitement or increased activity. So similarities are that they both involve psychomotor retardation, mutism and impaired responsiveness. But differences are that catatonia will have more movement abnormalities like waxy-flexibility, posturing, and depressive stupor will have very severe and specific depressive disorders and depressive symptoms which are not present in catatonia. And again, treatment wise also, in depressive stupor, we'll give antidepressants, we'll give psychotherapy. Sometimes ECT might be required if medications are not working or they are ineffective. In catatonia, benzodiazepines like lorazepam are used to manage the catatonic symptoms. ECT might also be considered in severe unresponsive cases. Prompt intervention is crucial to prevent any complications like autonomic instability, and death can occur in these cases. So that is why it is very, very important to treat them and treat them very quickly. So the importance of early intervention is very, very important. Depressive stupor and catatonia, they are actually psychiatric emergencies. Both depressive stupor and catatonia require immediate attention, immediate intervention. So time should not be wasted here. Prompt intervention leads to optimal outcomes. So like most illnesses, if early intervention is done, then there are less complications and recovery is also faster, recovery is better. Role of diagnosis and assessment. So accurate diagnosis is very important. Medical evaluation very, very important to rule out medical conditions. So in conclusion, for understanding and managing depressive stupor and catatonia, we need early identification and treatment. So a prompt diagnosis and intervention are crucial. Specialized care and support. So we need multidisciplinary team. We need neurologists. We need your emergency professionals. We need psychiatric professionals. So we need a team approach here. And we also need continued research to understand better what these conditions are, and also to develop some effective treatment strategies, because current strategies are, yes, there, but they are not effective in managing all patients very effectively. So in conclusion, I would like to say that catatonia is a complex neurological neuropsychiatric syndrome with significant implications on both mental health and physical health. And understanding this is very, very important for optimal care. That is why we are trying to teach you. Once you know what these things are, you will be able to identify, you will be able to treat this better. So with this, I end this lecture. If you have any doubts